Okay, so now we're going to start talking about the muscles and the function of the wrist. So the innervation of the wrist muscles, the radial nerve courses down the posterior aspect of the forearm and supplies all the muscles that extend the wrist. So if it's on the posterior side, if it's an extensor, it gets the radial nerve. Medial and ulnar nerves travel down the anterior aspect of the forearm and innervate all the primary wrist flexor muscles. So if it's a flexor that is primarily on the radial side, it usually gets the median nerve. If it's on the ulnar side, it usually gets the ulnar nerve. And we'll go through each one of them. So I like this diagram from the book. I think it's a really awesome diagram. It's on page 131. Because it divides the muscles, it classifies the muscles into sets. So the primary set that attaches to the wrist, and the secondary set that bypasses the wrist and attaches more distally. So it goes into the fingers, basically. So all the muscles of the wrist cross axes of rotation located at the capitate, and therefore they produce movement at the wrist. So you can have muscles that do flexion with a radial deviation tinge to it. You can have flexion with an ulnar deviation tinge to it. You can have extensors with radial deviation tinge and extensors with ulnar deviation tinge. So where they attach and where they're located with regard to the medial lateral and anterior posterior axis running through the capitate, that determines what their bias is going to be. So you're going to have flexors that they're primarily flexors, but they are more on the radial or more on the ulnar side, and you can have extensors that are more on the radial or more on the ulnar side. So we'll talk about each one of those. But I like this picture because it kind of sums it up, and you know me, I like graphs and graphics and things that a big picture sums it all up. So flexion and extension occur about the medial lateral axis of rotation, and radial and ulnar deviation occur about the anterior posterior axis of rotation. So the specific action of each wrist muscle is determined by the location of its tendon relative to each axis of rotation. So if it's anterior to the medial lateral axis, it's going to do wrist flexion. If it's posterior, it's going to do extension. If it's lateral, it's going to be a radial deviator, whether it's a flexor or extensor. If it's lateral to the anterior posterior axis. If it's medial to the anterior posterior axis, it's going to do ulnar deviation. So keep that in mind as we're talking about the muscles. So we're going to start with the wrist extensors. Extensor Carpi radialis brevis, or for short, ECRB. It's just medial to the extensor carpi radialis longus. So wrist muscles, gotta love them. They tell you what they do. Extensor, it extends. Carpi, the wrist, it's on the radial side, and it's the short one of those two. So we know right away it does wrist extension, insists in radial deviation. Another lovely thing about the wrist extensors, they have a common extensor tendon at the lateral epicondyle. So this is these are our tennis elbow muscles. When we have lateral epicondylitis, inflammation at the lateral epicondyle, it affects wrist extension. So like that tennis stroke, forehand stroke. The ECRB inserts on the base of the third metacarpal. So it's when you look at it, it is more, the base of the third metacarpal is more towards the radial side of the hand. That gives you that wrist extension and radial deviation, and it gets the radial nerve because it's on the posterior side. Okay, extensor carpi radialis longus, or ECRL. It's lateral, posterior, and superficial. Extensor, it extends. Carpi, the wrist. Radialis, it's a radial deviator. The name's just telling you everything. Longus, it's the longer one of the two. Common extensor tendon for the origin. How easy are the wrist muscles, right? It goes to the base of the second metacarpal, so it's still on the radial side. So that gives you wrist extension and radial deviation. But we already knew that from its name, right? And it's an extensor. It's on the posterior side. It gets the radial nerve. The extensor Carpi Ulnaris. What's that telling us? It extends the wrist on the ulnar side, so it ulnar deviates. And there's not a longus or brevis, so there's only one of them. So tons of information in the name of these muscles. The tendon runs in a groove between the head and the styloid process of the ulna. You can actually palpate that groove, which is kind of cool. It gets the common extensor tendon, lateral epicondyle, for its origin. It inserts on the base of the fifth metacarpal, over there on that ulnar side, so it does ulnar deviation. Wrist extension and ulnar deviation, but we already knew that from its name. And it gets the radial nerve. So wrist extensors during an activity or a grasp, the wrist extensors function to position and stabilize the wrist for activities involving the fingers, like making a strong fist or grasp. The contraction of those wrist extensors is necessary to prevent the wrist from collapsing into flexion because of strong flexion pull from the extrinsic finger flexor muscles. So do this right now. Make a tight fist and then move your wrist into flexion. How does that affect the fist? Move your wrist into extension. How does that affect it? When we go into extension, we're restoring some of the contractility of the finger flexor muscles, and we're able to make a stronger fist. So we can test that with the grip dynamometer in the lab. So the extensor muscles have to contract every time a grasp is made. If not, the wrist is going to collapse into unwanted flexion. So there is a picture in the book on page 135 where it shows someone with paralysis of the right wrist extensor muscles and how much weaker their grasp is. So really important functional consideration of the wrist extensors. So here it is. Here's the picture. So the person with the paralyzed wrist extensor muscle has difficulty making a grip because the finger flexors take over in wrist flexion. The wrist extensors can't neutralize that wrist flexion. So unless they regain the strength, whatever the cause of their weak wrist extensor muscles is, then you have to get an extension splint to brace the wrist in extension to keep those wrist flexors from overworking. And you can, by bracing the wrist into extension, you can restore some of the grip, which is pretty cool. So onto the wrist flexors. Just like the wrist extensors, their name tells you everything. It's great. They're the best muscles in the body for that. The primary wrist flexors include the Flexor Carpi Radialis, Flexor Carpi Ulnaris. We're getting some messages here. And the palmaris longus. And we'll talk about the palmaris longus. The secondary set of wrist flexors include the extrinsic finger flexors, which are the Flexor digitorum profundus, Flexor digitorum superficialis, and Flexor pollicis longus, which does the thumb. So we'll talk about all of those guys. And you gotta love the wrist muscles. They have those common origins. So common flexor tendon, it's on the medial epicondyle, just across the street from the common extensor tendon on the lateral epicondyle. So just across the elbow street. So the wrist flexor, the Flexor Carpi Radialis, just not even looking at the rest of that stuff, looking at the name, it flexes the wrist and it does radial deviation. And there's only one of them, there's not a longus and brevis. It's anterior, mostly superficial. It starts medial and then travels lateral to the insertion. So it has that line of pull for radial deviation and wrist flexion. Common flexor tendon at the medial epicondyle. The medial epicondylitis is golfer's elbow. That's the opposite. It's the flexion weakness, flexion strain. The base of the second metacarpal is the insertion. So there we are out on the radial side of the hand for the insertion. That gives us our radial deviation. Wrist flexion and radial deviation. We already knew that from the name though. It's on the radial side of the anterior portion, so it gets the medial nerve. Flexor Carpi Ulnaris. Its name is telling us it flexes the wrist and it does ulnar deviation. And there's not a longus and brevis. There's only one of them. It's superficial. It's ulnar and slightly anterior on the forearm, and it's the only wrist muscle with a carpal insertion. So the other ones insert on the metacarpals. This one inserts on the carpal. It inserts on the pisiform and the base of the fifth metacarpal. And actually the pisiform is embedded in its tendon to give it better torque. So it doesn't necessarily insert on the pisiform. It lives in harmony with the pisiform, we'll just say. We already know from its name it does wrist flexion and ulnar deviation, and because it's anterior and it's on the ulnar side, it gets the ulnar nerve. Palmaris longus, okay, its name doesn't exactly tell you what it does, but it tells you where it is. It's on the palmar side, right? Excuse me. Okay, water. Okay, my cat is not the only one with allergies. So the palmaris longus, it doesn't tell us what it does, but it tells us it's on the palmar side, which means it's on the flexor surface, so it's going to do flexion, right? It is absent in 21% of people. It's genetic. Usually in almost every class we find at least one or two people that don't have a palmaris longus. It's extremely visible because it passes superficial to the flexor retinaculum. I have a really prominent palmaris longus. You can really see it. And probably a lot of people in class do as well. So the tendon is at the midline. It's just barely lateral, so it gets the median nerve when you have it. It originates at the common flexor tendon, just like the other flexors. Unlike the other flexors, though, it inserts on the transverse carpal ligament and the palmar aponeurosis. So instead of having a bony insertion, it actually inserts on a ligament in the aponeurosis. So it assists in wrist flexion, but what it does when the 80 or 79% of people have it, it provides a little tension on that transverse carpal ligament and the palmar aponeurosis. So I don't know how much that's helping us, because obviously 21% of people can get along without it, but kind of an interesting little, there always has to be a freak in the group, right? So palmaris longus is sort of our freak. But it's pretty neat that it doesn't have a bony distal attachment. So the wrist muscles have to act with a lot of synergistic motions. The simultaneous activity of the flexor carpi radialis radially and flexor carpi ulnaris medially is required for pure wrist flexion. So they sort of their radialis and ulnaris parts neutralize each other, so their flexor parts can really work. So strong activation of all three flexors is usually required in conjunction with making a power grip. So holding onto that hammer, or holding onto a ball, or gripping to open a jar. Those are all power grips, and we need to activate those flexors in order to do that. The palmaris longus also helps stabilize the proximal attachment of a lot of the hand muscles. So when you have the palmaris longus, it has a stabilizing function. So it pulls on that transverse carpal ligament to stabilize that attachment. So the primary set of radial deviators is the extensor carpi radialis longus and extensor carpi radialis brevis. And then the second set of radial deviators is the extensor pollicis longus and brevis, the flexor carpi radialis, and the abductor pollicis longus and flexor pollicis longus. So we have primary and secondary radial deviators. So radial deviation is probably a pretty important task, since we have so many muscles that do it, when you think of it that way. So the muscles in both sets, the primary and the secondary set, radially deviate the wrist. The extensor pollicis brevis has the longest moment arm of all the radial deviators, but typically has a smaller torque production. So the abductor pollicis longus and the extensor pollicis brevis provide stability to the radial side of the wrist, along with the radial collateral ligament. So the abductor pollicis longus and extensor pollicis brevis, they form the tendons. They're two of the three muscles that the tendons form the anatomical snuff box, and they are stabilizers of the radial side of the wrist, along with the radial collateral ligament. So when we're doing motions like pounding a nail in with a hammer, we really need those stabilizers to perform the action in a strong and functional way. So when we're grasping and controlling objects in the hand, the radial and ulnar deviators are involved in those activities. Because of the strong functional association between flexor and extensor carpi ulnaris muscles, injury to either muscle can disrupt overall muscle action of ulnar deviation, because they both, their flexor and extensor functions neutralize each other, so the ulnar deviation can work better. So someone with rheumatoid arthritis, they have inflammation in most of the small joints in their body. It's an autoimmune disorder, and a lot of times they have pain in that extensor carpi ulnaris tendon. So people with rheumatoid arthritis are often getting hand therapy, and bracing can be really helpful, strengthening can be really helpful. Treatment from their rheumatologist might include medications that suppress the immune system and slow the breakdown of the joints. So rheumatoid arthritis is something that has to be dealt with all the time. It's not going to go away. And we see a lot of people with arthritis in the clinic, and rheumatoid or osteoarthritis. So the wrist joint is actually composed of the radiocarpal joint and the midcarpal joint. So some of the motion comes from one and some comes from the other. Even though you only have 2 degrees of freedom at the wrist, flexion, extension, and radial and ulnar deviation, our normal functional motion requires movement at both of those joints. So most often the wrist muscles are responsible for positioning the hand for fine motor skills.